Good afternoon and welcome to Australia at Home this Thursday, the 4th of June. My name's Emma Dawson. I'm Executive Director of Per Capita and your host for today, but by no means an expert on the topic. I am joined, fortunately for that purpose, by three eminent international experts. And today I'd like to start by acknowledging that I am coming to you from the lands of the Wurundjeri people of the Kulin Nation, and I pay my respects to their elders past, present and emerging. And I'm sure you'll join me wherever you are in acknowledging the traditional owners of the land on which you sit today, and can see that this is Indigenous land, Aboriginal land that was never ceded. So welcome to today's discussion, where we're looking at a viral history of the world. We're in the midst of a pandemic, the likes of which we haven't seen for a century, and it, as all pandemics do, has the potential to change our world in strange and unexpected ways. And so I'm really thrilled today to be joined here in my little in-house studio by three, as I said, eminent experts on the issue of pandemics, viruses throughout history. Professor Janet McCalman is with us. You've met Janet before on some of our discussions in Australia at Home. She's a professor in the Melbourne School of Population and Global Health at the University of Melbourne. And Janet's most well known for her social histories of Melbourne life, including Struggle Town and Journeying, and her history of the Royal Women's Hospital. Joining us from New Zealand today is Linda Bryder, Professor of History at the University of Auckland. She's known for her histories of tuberculosis, the Spanish flu, women's health, infant care, and oncology. And all the way from Sweden, where it's just gone 5 in the morning, Professor Per Axelsson, who's Vice Dean of Research in the Department of Historical, Philosophical and Religious Studies in the Faculty of Humanities at Umea University in Sweden. And Per's well known for his history of polio in Sweden, and more recently in his leadership in the study of Sami health and the Sami people of Sweden. So thank you all for joining me today for what I'm sure is going to be a fascinating discussion on the history of pandemics and how viral pandemics have changed the world. And if we go back, I think, and start with the Great Plague that we all learned about in school and that seemed like a thing of such other times until recently, the Black Plague. Janet, do you want to kick us off with a little bit of a history of the Black Plague or the Black Death?
Well, since our theme is what impacts these pandemics can have on the wider society and on the life after, the thing about the Black Death not only was its scale, and it was at that time confined to Eurasia, so it went east and west. It killed about a third of the population of Europe, and combined with war and famine, half the population, it's believed, of China. And we know very little about the really long-term impact in China. But it hung around then. The last big outbreak of plague in Europe was in 1764, I think, in Marseille. It came back every 30 years. It was a part of the reality of European life. And it didn't seem to give people immunity, which was one of the problems with it, while the death rates continued. And the last big outbreak in England, the Great Plague in the 1660s, killed half the population of London, for instance. So these are big numbers, but in many ways, the two big legacies are not what a hopeful economic historian tweeted the other day, was that it improved wages because there was a shortage of labour after. It did that a bit in England. But the real legacy is actually cultural and in the impact on the Christian religion. And so the obsession with death and sin that becomes so central to particularly Southern European Christianity, and lingers still in Spain and in Latin America, the danse macabre, the obsession with punishment of the body, great armies of people roaming the countryside, whipping themselves to bloody messes for their sins. And so the impact on religion was profound, and the emphasis and fear of sin in Catholicism can really start from there. The other one was, of course, the way it fueled anti-Semitism. So the Jews were blamed for the plague until the cats were blamed for the plague, and there was a cat massacre much later on. But anti-Semitism became also the great signifier of the Black Death. And then it really stayed around and hung around in the north of Africa, in the Middle East, and continued to sap any chance of development, economic growth there. And then it became a pandemic just at the turn of the 20th century, and where it reached Australia and led to a very big clean-up of the rocks in Sydney, and to, in Victoria, to a ban, a big campaign to get rid of rats, and where children were paid tuppence, 2 pennies, 2 cents for every rat they caught, and that they were to wash their hands in boiling water, and there was a fall in infant mortality as a result. So that's the Black Death. By the end, Chinese were being blamed because it was at ports and there were Chinese crews in ships. But what superseded the Black Death in the European and North American mind was cholera in the 19th century. And just briefly, what was powerful about cholera was that it was not blamed on a scapegoated group. It wasn't blamed on the Jews or anyone else. It was blamed on the government. And what erupted in the first big pandemic of the 1830s were massive riots against the government, where people by now were convinced that the government was trying to poison them to reduce the population. The extent that in Hungary, the mobs found barrels of chlorate of lime stored in the count's castles, and so the counts were murdered. In England, massive riots, and what this convinced governments from then on to do was to actually not declare that cholera had erupted again, because the fear of riots and the fear of what it would do to trade was greater than the disease. And anyway, it seemed that the disease was a disease of the poor, and perhaps it didn't matter if they died off.
Too cynical, Janet, but I think a very good point. So we really see throughout history that the reaction to such sort of massive viral infections is primarily one of primal fear amongst the population, and they're looking for someone to blame or some way of assuring themselves that it's not some random thing that will strike them down. Before I go on, I do want to remind everybody that if you have a question for any one of our panellists today, please jump into the chat function and note it down, and our moderators will make sure that question gets to me. But Janet, there's a clear parallel there with some of the behaviour we saw early on in the days of the COVID-19 pandemic, with not quite rioting here in Australia, but certainly people becoming quite irrational about their concerns and food stockpiling and that kind of thing. So effectively, this is something that history told us to expect.
Well, what happened, there's a wonderful piece written by an historian called Richard Evans about epidemics and revolution. And although there weren't direct causal relationships between the outbreaks of cholera through the 19th century in cities, there was a coincidence of forces that were bringing out both of them. And so with every big cholera pandemic in Europe, there were major political disturbances and attempted and failed revolutions. So there's a huge amount of political violence associated. So it's like today, where there are other issues generating the violence in America, but the pandemic certainly doesn't help. And it's all part of a general collapse, which we have seen before, and which was resolved by very forcible and oppressive government action, particularly in France and in Germany. But on the other hand, there was another response, and this was what really has been at play now and comes into play when we get on to polio and tuberculosis, is the role of the rise of the state. Mm. And by 1868, England had a state apparatus for controlling disease and ensuring safe food and water, which at the height of laissez-faire capitalism was an extraordinary intrusion into private industry, private business, private homes. It was compulsory for children to be inoculated against smallpox, and there was a big anti-vaccination movement. And so the state starts to assume powers over individuals and over the private sector, because the only way you can protect people against pandemics and epidemics and germs is collectively. So this changes the balance, and it gets us into the era of public health. And that's where other profound health problems like tuberculosis. And this is where Linda did this wonderful book, which was her DPhil originally, which really, I'll never forget the impact it made on me, on what she described as the power of the state assumed over tuberculous people. And it's something, even in these times of COVID, we can't imagine the state doing that in our private lives.
Yes, well, I do want to bring Linda in there because I think it gives us some fascinating insight. There's been the voices on calling for too much state intervention in this COVID-19 pandemic. It's time to reopen the economy. But Linda, this is nothing compared to what we saw in the response to tuberculosis, according to your work. You might need to take yourself off mute, I think. Okay.
Thank you very much. Yes, just to as a prelude, whatever, to what I'm saying here, though, is that when you introduced the seminar to the webinar today, you talked about the history of viral disease and or viral, whatever it was called. Well, of course, and I was asked to talk about tuberculosis as one of my topics, and of course, it's not viral; it's bacterial. However, it's still an infectious disease, so I think we probably get away with that one.
Absolutely, absolutely.
And the second thing is, and thank you for mentioning my book, and I just want to, again, sort of preface anything I say. My studies were focused primarily on Britain. And so what I'm going to talk about really is tuberculosis in a Western world setting. When I come to talk about the flu pandemic later, I would like to talk a little bit more about our Indigenous people, Māori and Western Samoa. But when we're talking about TB here and the rise of the state, and public health, this was really a Western worldwide initiative around the late 19th century. All countries in the Western world, and that's really I guess it is significant because it's affected the way the modern state and world has really responded to infectious diseases. So just as that as a preface. So what happened with TB? Well, what happened, one very significant factor I think we have to remember is the discovery of the bacterial cause of the disease in 1982 by Robert Koch, because this significantly changed the public health and the public response to this particular disease. Some of you will be very familiar with that kind of 19th century literature where tuberculosis was romanticized. It was, these fading women who died very delicately and romantically of this disease, that not being able to withstand the rigors of sort of modern urban living. It was called consumption, of course, as well. And I think you're probably all familiar with that literature, a very fatalistic attitude to it. Well, this all really did change once they discovered that it wasn't this romantic disease at all. It was a common infectious disease that could be prevented by stopping the spread from one individual to another, through droplet infection, much like our current COVID is spread, in fact. It changed the strategy. So apart from anything else, you got organisations, preventive organisations like in Britain, the National Association for the Prevention of Tuberculosis, which started public health education campaigns attempting to disprove this idea that it was in any way romantic. And in doing so, they showed it to be a really horrible, a nasty disease that was spread in squalor and amongst the most dissolute people in the population, as well as people who had somehow were genetically disposed to catching this disease. So this kind of image that they were portraying in their attempt to check it was a very unpleasant image, which means that anyone who had it, was not likely to admit it. It drove it underground. So it had exactly the opposite effect of what they had hoped through this public education program. It actually led to a lot of subterfuge and people trying, not admitting to having the disease. That's one effect I think that we have to keep in mind, and I can come back to that a bit later, about modern public health, but we were talking about the rise of the state and what the state campaign against tuberculosis. And yes, it was pretty draconian. I mean, I was, well, talking to Janet about the, places like in San Francisco, where they had plainclothes policemen traveling on the public transport to try and catch people who were spitting. So there's this huge anti-spitting campaign, because that was, of course, how it was spread. And people who were caught were fined $500, which was a lot of money in the first decade of the 20th century. The power of the state in to try and prevent it was quite significant. They also set up institutions which were for treatment, but in fact, you know, they were also for an attempt to isolate people who had it, in a way, again, contributing to the attempt to stop the spread of the disease, but really under the guise of treatment. You can ask me about that again a bit later. So well, I'll stop there. I was going to go on to talk about the lessons, but I think you want to ask about that for the current situation.
Yes, I think we'll come to some of the lessons for the current situation at the end. But I think, you know, the case study of tuberculosis, and you're quite right that the event's called the viral history of the world, but we're really talking about the widespread infectious diseases, whether viral or bacterial. It's interesting to me as well that, and perhaps unsurprising given my studies in economic inequality, that these pandemics and massive widespread epidemics of different diseases do tend throughout history to be concentrated in those that have the least resources. And we're seeing that play out again now, of course, as well, particularly in the US, where it tends to be disproportionately people of colour and people on the front lines that are exposed to disease. I want to move now to talk a little bit about the Spanish flu, which I know is something you've also...
Just one tiny comment on that. Yes, TB was very class specific. And what was interesting is that the dominant public health program and the state, I suppose, did not focus on socioeconomic or living conditions, but really very much in the early 20th century on blaming the individual.
Interesting. And even though the government sort of accepted responsibility for addressing these things, there was no kind of acknowledgement of the wider social or economic policies that might contribute to that?
No.
Interesting and not surprising. And so the Spanish flu, Janet, do you want to lead us into a bit of a discussion about that? Because it's the most obvious comparison that's being made with today, or perhaps because it's just about in living memory for some people. You may need to unmute yourself again, I think.
The strange thing about the Spanish flu is how it was forgotten. And it was buried by the memories of the First World War. And yet it killed far more. I mean, 100 million, you know, and the death toll, particularly in India, which is very horrific, but it's Africa we don't know about. We know that if it did get into Indigenous communities in Australia or New Zealand, Per can talk about Sweden, it was devastating, as was tuberculosis, by the way. The great killers of Aboriginal people in Australia were first smallpox, then venereal disease, and then tuberculosis, and they were very profoundly susceptible to it. And still so in the 20th century. They're still getting things like miliary tuberculosis in the 1940s, which was unseen amongst white people. So the flu is this global disaster which people in a very strange way almost take in their stride because they've been through the war perhaps. But the Australian story is a small story compared to even New Zealand, which had a much harder time. So I think I should hand over to Linda.
That silly mute button. Actually, just following on from what Janet's saying there about it being the forgotten pandemic, it is so interesting how it never really made it into the history books, for example. And you can say obviously the First World War must be a big player there. But I was reading about the flu pandemics of 1957 and 1968 as well. And while they weren't quite on the same scale as 1918, they certainly killed in millions, and yet also forgotten. I kind of wonder whether that's the nature of these crises, that maybe people will look back at our one as well and say, what was all the fuss about? I don't know. I'm just throwing that out there for people to think about, because people tend to be a bit fatalistic, and these things, like life goes on kind of thing, and you get over it. And because I did notice that was one thing with studying the 1918 influenza epidemic, everyone called it the forgotten epidemic. No one knew about it. And I lecture on it, and no one knows about it until this year. I lectured on it this year to a class of undergraduates, and I said, who's heard of the flu, 1918 flu? And they all put up their hands. Suddenly everyone knows about it. And that was unusual. Anyway, you asked me to talk about New Zealand, and New Zealand had such a different experience from Australia, which managed to keep it sort of at bay, in abeyance for a bit longer, although not totally. And so it makes a really interesting comparison. But how it arrived in New Zealand, it killed 8,500 people here, by the way, which if you translate it into how many it would kill per rate of population as we have now, that would be 42,500 people. And in the COVID, we've had 22 deaths. So just putting it into perspective there, the differences. It was huge in its impact and effect on the population. Came really with the troops. Coming back from the First World War, there are different theories about how it arrived here, but I think the important thing is that it really came early October of 1918, just at the conclusion, as Janet said, of the First World War. And what's interesting, I suppose, is to talk about the community transmission, not so much how it entered the country or the lack of quarantine, but what happened once it came here. The Public Health Department attempted to do a fairly rigorous lockdown of, if we call it lockdown, that's a very modern term. They didn't call it that in 1918. Closed schools, closed all public meetings like races, billiard halls, apparently they were really popular then, churches, hotels and bars. All of this was closed down. But in fact, when I looked at the announcements in the local papers at the time, I found that there were a lot of public events still happening. And so it was a bit half-hearted compared to our current, like New Zealand went into this lockdown, level 4, was very comprehensive and obviously worked. But what happened in 1918 with the end of the war, the armistice was prematurely announced on the 8th of November, and everyone rushed out into the streets to celebrate right at the height of this pandemic. One newspaper report talked about the people in Auckland's centre in Queen Street, calling them one mass of, I quote, laughing, crying, coughing, and obviously sick people. They all came out, they congregated, and it just spread like wildfire. And it spread first through Auckland and then southwards. As I said, the death rate then was 8,500. It was so very different from the current epidemic in the sense of the age distribution. And Pierre was talking about this earlier, well, before the meeting today, how most of the current ones are in the care homes, the rest homes, whereas the 1918 flu really killed people in the prime of their life, which was, between the ages of 20 and 45 were the main age group that succumbed to this disease, which was very sad in the sense of that these people had survived the 4 years of war and came home and then died of the flu. Māori population, it was 6 times higher than the non-Māori population. Again, that's hasn't played out in the current epidemic. Why? Because it's generally been assumed that they had underlying health conditions at the time associated with socioeconomic status and living conditions, like and in particular tuberculosis, which made them more susceptible. New Zealand also had administration of Western Samoa at that time, and that was also another crisis, which our Prime Minister apologised to the Samoan people quite recently. So about a ship that went to Western Samoa was not quarantined, had cases on board, and again it spread like wildfire, killing about a third of the adult population.
Linda, I might bring Per in here because I think there's an interesting parallel with the impact the Spanish flu had on the indigenous peoples of Scandinavia there as well. Is that right?
Yeah. Yes, that's right. Good morning, everyone. From Sweden here. Well, there hasn't been much research done on that. I will be quoting one researcher called Svein-Erik Mammelund, who's actually the one who's done the research on the effect in Norway on the Spanish flu and the Sami. The Sami are situated in 4 different countries. So it's the north of Sweden, north of Norway, north of Finland, and north of Russia, called a peninsula. But there he can show that they were actually hit much harder than the rest of the population and the rest of ethnic groups. But what's interesting in the context of Sweden and the Spanish flu is that it came here as well in 1918 and then came back in the second wave. And in a sort of at the very end early 1920, in the very northern town of Arjeplog, which is also, you could say, situated on traditional Sami land, a huge amount of the population fell ill, and that was where we had the highest death rate during the entire epidemic. And it's a very sparsely populated area, very long, far away from any population centers, and so on and so forth. And I think people thought that it would be over by then, but it wasn't. But in Sweden, it was 37,000 people that actually died from influenza in Sweden, and that was a population of 5 million. Mainly 2 population groups. The military was the big spreader, along with people at school. And
interesting. But the same death rate is
15 to 40 is what we say here. That was the main death rate. It's 15 to 40. So the Swedish state was criticized afterwards to not being adequately handling the pandemic and not being.
Well, that in itself is an interesting parallel to today, isn't it, Per? Because there's been quite a lot of criticism of your current administration for its so-called herd immunity response. So should that have been anticipated given Sweden's history of dealing with epidemics?
Sweden has had a good history of dealing with most epidemics, but at this point, we're talking about the COVID now, I guess. Mm-hmm. I would say it's very early to speculate if it would come in a second wave. We don't know anything. We're 3 months into the epidemic so far here, but it doesn't look that good, especially when it comes to the group on living in elderly living in care homes. That's where it's very much apparently hit very hard.
Yeah. And are you aware yet? Do you have reliable enough data to know what the impact has been on the Sami people of the current pandemic?
That's one of those things that you will never get from Swedish data. So that's one of the things that we are continuously being, we don't do ethnicity in population statistics. We don't collect in official statistics anything around ethnicity. So we would not be able to do that easily in any way.
Interesting. Certainly, different countries' approaches to measuring.
We have excellent data. We are probably one. Well, in other cases, epidemiological data is gold standard in Sweden.
Yeah.
When it comes to ethnicities, nothing.
I have a question that Shiva on the chat wants me to read out rather than ask herself, and I think this goes to the discussion earlier about the tendency throughout history to seek someone to blame when epidemics and pandemics take hold. And she says here, because this kind of pandemic has happened in human history repeatedly, what are the real chances of human manipulation in the case of COVID-19? Of course, we've heard various conspiracy theories about labs in Wuhan. I think what Shiva's getting at is, given that pandemics are a fairly regular occurrence if you take a long view of history, what likelihood is there of some kind of human involvement in this pandemic? Can we knock that on the head right now? Who wants to take that question?
I've ventured to say very, very little. Certainly not in the past. And if they were trying to develop a biological weapon that really bit them in the foot, they shot themselves in the foot in China, so no. I mean, accidents happen in labs. It's possible that, you know, there's not very much smallpox left in the world, but there's some down in Geelong in a special lab down there. It is possible for things to escape, perhaps, that sort of conspiracy theory doesn't work. I mean, I think what Linda has given us a very good chronology of is the shift to blaming the individual. And that might even be that the individual is to be blamed because they're poor and their poverty is their own fault. So this idea, it's been a great battle in public health and social medicine to get the idea that people's place in society and the society and the structures of that society might also be responsible for the susceptibility of certain groups to becoming sick, which is what's happened with COVID. So that people with a long history of oppression, constant stress, fear, bad diet, a higher incidence of diabetes, all of these things flow into increasing your vulnerability. It's got nothing to do with the melanin in your skin. It's got everything to do with the history of your life, your parents' life, and your grandparents' lives. And so, but this shift to blaming the individual has been is now still the great battle in health, because, you know, one of the arguments has been that in America that the Black and Hispanic population have died from COVID because their health is so bad, and that's their fault for getting fat.
I was just going to add into that, because that's something that I found again with looking at the 1918 influenza epidemic was, and a point I made in my thesis on that was that people's prejudices seem to come out at a time of crisis that is sort of more perhaps underlying, more subdued perhaps in other times, although they come out, you know, on other occasions as well. But a health crisis does seem to lead to people trying to point the finger and blame. For example, in New Zealand in 1918, the Asian community was blamed for spreading it. Now, the Asian community in New Zealand was very small and very law-abiding and very clean, and yet all of this public prejudice seemed to come to bubble to the fore about these Asian people spreading it. We didn't have a white immigration policy like they did in Australia, but even still there was a lot of prejudice, and that really came through in this crisis situation. And similarly, in 1918, women were really blamed for spreading it, for not being good housewives and mothers, and not keeping their family healthy, you know, and safeguarding them against this flu. So again, it's kind of these societal prejudices that come to the fore in a crisis situation, which you can see more clearly when you look at one not in the present but in the past, I think. I wanted to add that too, Janet's.
Well, this is one of the bad effects of germ theory. But now you could, you know, locate danger and disease in particular groups of individuals. So And it also leads to racialised theories about disease.
Yeah.
So germ theory might have got us further along the path to better clinical medicine and public health prevention.
And vaccination. Yeah.
Backwards morally.
Definitely.
And so, and the stigma against, say, tuberculosis sufferers was horrific. And even my father had it and kept it as a secret from us. And it was a secret all his life. So, but I mean, the other one, the interesting one is polio too, because, and that's where Pear comes in, because polio, the great battle was how did it get spread? My budgerigar, Reggie, was put down the toilet by my mother in 1956 because the story was going around that the polio was being spread in the air by birds. And she didn't like Reggie, and Reggie had to be a mistake. This did not prevent me from catching polio, which I'm sure I caught at Box Hill State School in the toilets, which were atrocious because the baby boomers the school was bursting, and it seems there was no facilities for washing hands. And that was the key to preventing polio. But the story of polio in Sweden is very interesting.
Yes, so can we hear a little bit about that from Per before I go to some questions from the chat? Per?
Yeah. Well, Sweden was hit very early and very hard of polio epidemics, and of course that was it was called the infantile paralysis. It was mainly kids initially that was that got polio, and initially all of you can actually, if you were born in 1900 to 1910, you would be accompanied by polio epidemics your entire life until you become 50 or 60. We had the vaccine in the mid 50s, so the higher the death rate was high, but the actual morbidity was even more staggering, and people that got polio was also they were visible in society. So they reminded you that you could actually you had the paralysis, you could actually you continued to be part of society, but you were looked upon as a polio victim, and not properly in a good way. But the thing is, for a long time, medical research, and this is when we had bacteriology, but this was a virus. Polio was a virus. So for a long time, they didn't understand the disease transmission. How did it actually transmit between people? So these popular conceptions on what actually caused the disease, took hold of the discussion. And you can even see in the 1910, 1920, 1930, doctors saying you should not eat apples that have been lying on the ground. You should not kick leaves, because this disease happened. 80% of the cases was appeared in August to September. So there was an autumn disease in Sweden. In the US, it was a summer disease. So here the idea of the transmission was connected to when it actually happened. So here you were allowed, especially during the autumns, to you shouldn't do certain things like eating rotten fruit and fruit that's been on the ground or some stuff like that. And it was not until the late 40s, that they actually understood that it was not only one virus, it was 3 viruses that you needed to sort of find the cure or the vaccination to cure polio.
Can I add a little bit about Australia there? Because there was a big outbreak in 1954 when we had our memorable visit by the young Queen Elizabeth II, the time when Sir Robert Menzies quoted lovely poetry at her. I did but see her passing by. And the problem was that it had been raging in the eastern states, and it was going to come to Western Australia. And the idea was perhaps they should not have the royal visit to Western Australia. This provoked a constitutional crisis in which Bob Hawke's uncle, who was the Premier, said they would secede from the Commonwealth if the Queen wasn't allowed to come to Western Australia. So then they argued maybe they'd just keep her on the royal yacht in Fremantle, and she could wave from the yacht at the people on the shore, who no doubt would be congregated, but that wasn't good enough either, because all those children had been practicing for months for their big display in the Wacker. And so they'd all got their costumes and was all ready for the big display. They couldn't possibly stop them from doing that. So someone then had the bright idea to provide all the children with a little towel and a piece of soap. And they didn't have a single case.
Sometimes the simple things then, Janet.
Yes.
Well, speaking of ways of addressing epidemics and pandemics, we've got a question from Maureen Walsh in the chat. And I understand Maureen's happy to unmute herself and ask that question. Maureen, can you go ahead?
Oh, yes. I can't remember when it stopped. I think it was in the early 70s, I had my last x-ray from a TB caravan that used to come in the streets. And this also found many other health issues with people. So I'm just wondering whether that would be any good, because the people who don't have symptoms can carry COVID-19. Would it be a good idea to have most people tested? Similar way where they can go somewhere and be tested.
Yeah. I mean, testing and surveilling healthy people is a very 20th century public health idea. They never would have thought of doing that in the past. And one of the models was the mobile van for tuberculosis, mass miniature radiography. And communities used to vie with each other to see who could get the most, a bit like the blood transfusion service, like we've got 93% of our lot around the country as they moved around. A good idea, but I don't know, because each epidemic and virus or bacteria is different. But I did also have a student who did her PhD on this later period of tuberculosis. I focused more on the first half of the 20th century in my thesis, but she did it on New Zealand, and in this period where they had these vans going around doing this mass screening, and found that in fact it made no difference to the rates of the disease. So it was kind of like, oh, okay, all that effort. Sorry, we can't hear you, Maureen. You're muted.
Sorry, Maureen, you're muted. Can you unmute yourself again, please?
But I'm not saying that testing shouldn't happen at all. I mean, I think testing is a good thing.
Yeah. So this is what I'm probably trying to get at. Do you think there should be more concentration on making everyone go and have a test?
You still might get it later.
Because even that COVID app is not much use if not everyone's tested. It doesn't seem to have any. Yeah. Anyway, that's my.
It might be. I mean, it's just really also depends on, in the history of screening, sometimes the methods are not are not completely safe. You can get false positives and false negatives. And so you give people reassurance when they actually shouldn't have reassurance, or you make them fearful when they needn't actually be fearful at all. So you'd have to have a test that is 100% effective for this really to be a good option. Be it is. Maybe the COVID test is. I haven't heard that it's not, but I'm not an expert on that. Pierre wants to say something.
No, I'm not an expert either, but the thing is, once you're tested, you get a result, right? But then if you meet someone on the street in 10 minutes, and you open a door that someone has I don't know, your test is what's going on at that particular minute when you enter the testing room, but
You might,
after
even
that,
10 minutes later, you might become infected.
yeah, that's one of the problems, right?
False security.
Yeah. Per, while we've got you there, there's a question earlier on, or a comment really from Terry Ann Kingsley. Terry Ann, if you're still there, did you want to unmute? And it refers to what Per was talking about before, about the lack of disaggregated racial data in Sweden, about the impact there.
Yeah, I was just really curious about that. Not having that separate data or that added data based around race or other groups does seem to turn a blind eye to, you know, if there is institutionalized racism that prevents people of a particular group being able to access healthcare services, say, at the same level as everyone else. You see it in the US, Black mothers have a higher rate of death during pregnancy and around that natal time than others, even when you control for income levels, that sort of thing. Without that data, you'd be hard put to prove it and to design anything that can help that. So is that a lack, not having that data?
Yes, thank you, Terry Ann. Yes, for sure. This is something that Sweden has been criticized all over since the 2007 and onwards, really internationally, by the WHO and others, that we do not collect that sort of information. But that's in Europe, that's not an uncommon thing. They focus on two things mainly in Europe. That's citizenship and migration. So that's what we have information on. We've blacked out ethnicity and race and stuff like that. And we also, what's also different from Australia and New Zealand is that we don't have a census in the way that you guys have. We have, when you're born, you get a personal number and that follows you through life to the grave. We don't have a census where people, you know, where you fill out a form where you can self-identify to belonging to certain groups. This number, it follows you through when you go to school, when you go to the doctor, when you know, everything basically, if you go to the bank as well. So it's very easy. We produce data all the time. This is something, the number is in every system. So we produce data all the time. We don't need a census in that particular case, but we are not open for studies on ethnic groups, for instance.
Can I just add a bit there? So definitely we do that here, and it is self-selection. But traditionally, you know, I could see maybe there could be an issue in separating out these groups. And when they stopped BCG vaccination in schools and decided that it was under control and they didn't need it for tuberculosis, they realised that they probably should still do it in some areas which were predominantly Māori and Pacific because they had higher rates, and yet they didn't really want to target it to ethnic groups because that was almost like saying you are inferior, you racial group have this disease, and we're talking back to that stigma aspect of TB. So instead what they did was give it to certain areas rather than certain peoples to try and avoid the kind of stigma of an ethnic group being stigmatized because they have more prevalence of, say, TB or sexually transmitted diseases or whatever. So I don't know if that's a consideration in Sweden or you just don't bother.
I mean, as health researchers, how frustrating is that to you in your work? Because obviously these considerations are essentially cultural or political in nature. There's a cultural decision in Sweden to not differentiate people by ethnicity. Everyone's Swedish, they're a citizen or they're an immigrant. There's a desire politically not to target a particular ethnic group and perhaps exacerbate stigma around that. And these are, depending on your perspective, arguably worthy goals. But as health researchers, to what extent does that frustrate your ability to understand the nature of diseases, and then for those on the front lines trying to develop vaccinations or cures? How much does it stymie that work?
Well, I can speak a little bit on that. Of course, it's difficult if you don't know the extent of, you know, anything in an indigenous population, for instance, or an ethnic group. How would you know if you do something specifically if it works? So that's of course something that we all keep coming back to. But the Swedish system, public health, has been designed to give the same sort of treatment to everyone, and that's been very successful generally. But it's not sensitive in that way that you are describing, Emma. But we try to sort of keep public health, like vaccination programs and everything like that, is for everyone in the same way.
Yeah,
it's across the board.
Thank you. There's an interesting question from Bob Phelps on the chat. Bob, are you there? Would you be happy to unmute and ask your question if you're still on the line? Bob. Well, we may have lost Bob, or that could be Bob that stepped away for a moment. Perhaps I'll read out his question then.
there's a Bob one who's missing.
Yes, there's a Bob that might have just popped out for a cuppa. I think we should have given him some warning. It's my fault. Bob asked, the origin of COVID-19 remains unclear, whether it's bats or food and wildlife trade or gain of function research in high security labs. Are stronger regulations, more precaution and preparedness also required on GM organisations in labs and factories and in nature? He says GMOs are no longer notified to the gene technology regulator for assessment or licensing before release, and should Australian governments reverse the deregulation of these new gene editing methods, which they did last year? I'm not sure I even understand that question fully, but if any of you, I think, you know, essentially what Bob's talking about is...
Yeah, I think I do.
Privatisation. Go on.
It depends what the genes are for and what context is. So Bob is very opposed to GMOs, which there's a strong argument that they've actually made a very big difference to improving a lot of food supplies in a world that's very short of food. So, you know, whether something is going to, you know, a gene is just a gene, it depends on what it's in. So if you're doing things like that in bacteria, then, or a virus, then that's different. But the gene is just a gene, and if you switch a gene, it's just a gene. But the relationship to the other genes of the organism it belongs to is what matters.
Yeah, thank you. A question from Mark Steele, who's asked that I pose this on his behalf, as we've got a shy crowd today, other than Maureen. And I think this is a good one. There's a suggestion gaining currency in some countries that we're just going to have to tolerate ongoing deaths as the price of reopening the economy. And that's certainly been a discussion that's been live here in Australia, with some economists suggesting that the price of the economic carnage is too great and we just have to sacrifice a certain number of lives. Does history suggest, asked Mark, that society will simply tolerate an ongoing daily level of deaths as the lesser of two evils?
No.
In a nutshell, Linda?
I'm not sure. I mean, I was rereading Pepys's diary for the 1664 plague epidemic. What's extraordinary is the way he normalises it. I mean, we think of Defoe's Journal of a Plague Year, but that was a fictional account written more than a century later. Pepys grew up in a world where plague kept happening, and the poor were of no consequence. And he once mentions walking through the street and there's a lot of dead bodies, and it's shocking to us, but they normalised it. And we've seen, even in the 20th century, a terrible degree of normalisation of outrageous and terrible deaths in wars, in famines and so on. What's being asked today in this sort of idea, and it's a very frightening one, because what's going to happen, I think, in a country like Australia, where pray that we don't have a second or third waves, but we've done very well. And what they will say, like they said after we successfully beat back the GFC, it was all unnecessary. There was no need for all that government intervention. Thankfully, this has been done by a Liberal government, but if it had been done by a Labor government, we'd have had no end of arguments that this is the damage to the economy is far too severe, because people find it hard to believe that something like COVID can be so dangerous, which what seems to me has happened in Sweden, Per, by the way, that they underestimated the germ. I think there's a very great danger that COVID, if they don't get a vaccine and it's not made available globally, it's going to be in the world for a long time, and it's going to keep coming back like plague did. And the world will normalise it, that it's okay for it to appear in Malawi, and we just won't go to Malawi. Not that we care about exporting things to Malawi particularly. So this is I think there's a very real danger that what has happened this time, I think, is that our tolerance of a lot of people dying suddenly in a horrible way has actually gone down in a way that we didn't have it before. So compared to 1919, people were more accustomed to lots of deaths, not only in the war, but there'd been the Russian flu in the 90s. There were the diphtheria epidemics. People still died of measles, children died of measles. A lot of people are dying of TB. Our tolerance of death is very much lower.
Yeah. I said one in 10 women still died in childbirth 100 years ago.
Yeah, exactly. But that was always seen as a tragedy.
Yeah.
That was always different. That was, and in fact the figures are, it didn't really make a difference to the population, but infant mortality was the one, and death was associated with infancy.
Yeah.
So people were much more accustomed to death. It doesn't mean they grieve any less. We are not now, and I think there has been a sea change in the free world's that we have been prepared to sacrifice our economies for the sake of saving lives. But certain countries have not done so with a full heart, like the UK, like the US, and of course Brazil. And that's where, when government has failed to act properly, the death rates have blown out.
What do those three countries' leadership have in common, I wonder?
Well,
we're very close to time, so I'm just going to ask each of, I think, Janet, that was a really good
just the normalisation of disease. I think the prime example of that is AIDS. HIV, which
that's right.
Huge fear of it when it first arrived, and then after a while, it's only those gay men who are going to get it, and people from blood so people didn't care about it anymore in the same way. So I think that Janet has a really significant point there about normalisation of disease.
Thank you. And was there anything else I wanted to ask both you and Per to sort of reflect on, based on your historical knowledge, what you see, what's next? What's the next stage in this pandemic? Per, perhaps you want to go first. What might a second wave look like, for example, or where do we go from here?
Oh, that's a really tough one, right? I'm an historian, so predictions is difficult. But I would say, I think like influenzas and epidemics, they do come in second waves. That actually is what history is telling us. So I think we need to be prepared for that as well. And I'm not sure that Sweden is feeling that we are, but the Public Health Agency are they've taken this stand to have a quite open society, and we're trying to live by that with social distancing and so on and so forth. And we'll have to see.
Thank you. But we have reached 2 o'clock. Time flies when it's a really interesting conversation. I think we could have extended this for another hour at least. I've still got a ton of questions, and the questions are now after a very slow start starting to come in on the chat as well. So we'll keep a record of that conversation for people who participated today. Do get in touch with us if you want to pose any further questions to our panellists. I'm sure I could arrange a sneaky email to them after this conversation. But please, thank you very much, Per and Linda and Janet, for your time and expertise today. Thank you to the team at Australia at Home and Essential Media and the partners of this platform, which is becoming a really great forum for these conversations during lockdown, and one I hope will continue as we emerge blinking into the winter sunshine on this side of the world, Per. I'm envious of my colleagues and relatives in the UK that are coming out of lockdown into summer. But thank you all again, and thank you to those of you who joined us today. We had over 120 people on the line, so it's certainly a very topic that has a lot of interest for a lot of people.
Thank you, Emma.
Thank you.
Thank you
for coming.
See you at the next Australia at Home.